and welcome to Good afternoon and welcome to our medical lecture series. I am Dr. Galit Hakim, Assistant Vice President of
Health has stopped screen share.
I apologize for the technical difficulty. I was saying I'm Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Juan Cedeno. His presentation is titled Surviving Prostate Cancer, What is Next? Dr. Cedeno is a urologist at Baptist Health. As a minimally invasive reconstructive urologist, Dr. Cedeno performs complex surgical procedures using innovative robotic platforms. He specializes in general urologic care and transgender care, placement of genital prosthesis, tissues harvesting from urinary tract reconstruction, treatment for sexual dysfunctions, and gender reaffirming surgery. Dr. Cedeno earned his medical degree from Universidad de Carabobo in Maracay, Venezuela, where he worked as an assistant professor. He attended Jackson Memorial Hospital for his internship and was recognized as one of the interns of the year. He then attended Mount Sinai Medical Center for his residency in neurology, during which he served as a chief resident. In addition, he completed a fellowship in reconstructive urology from University of Illinois in Chicago. Dr. Cedeno has authored and co-authored multiple articles, chapters, and studies, and has participated in multiple international and national conferences. Please let's give a warm welcome to Dr. Juan Cedeno. Dr. Cedeno, thank you so much for joining us this afternoon, and welcome to our team at Baptist Health. The floor is yours. Unmute yourself, Dr. Cedeno.
All right. Hello, welcome everybody. Good evening. I hope everything's going well. So after this introduction, I would like to start.
You have started screen share. Participants can now see your application. You are screen sharing.
So I was very well introduced by Dr. Hakim. Thank you everybody for having me this afternoon. So it's a pleasure for me speaking with you today, especially the topic that we're talking about. Most of our exposure and expertise in urology, what we are trying to get, like where we in medical school, is close to none. And some of the times we don't have this opportunity to have somebody, a specialist like me, to talk with you guys. So one of the topics that I want to discuss is about what's going to happen after you underwent a surgery of prostate cancer. This is a program that we are trying to implement little by little. This is basically who I am, which already been introduced by Dr. Hakim. Okay, I don't have any disclosure. And this is what we are going to discuss. First, brief talk about prostate cancer, mainly about statistics, okay? And then we're going to focus on erectile dysfunction, stress urinary incontinence, and overactive bladder after the treatment. This is in the sense of what is being a survivor cancer. Okay. And sorry about that. Okay. What is to be a okay. Sorry about that, friends. Okay. All right. Going back. And what is to be a cancer survivor patient? So speaking a little bit about the prostate cancer, worldwide prostate cancer is diagnosed in approximately like 1 million men, and is contributed to be the 3.8% of cancer deaths in 2020. Okay, prostate cancer was most frequently diagnosed among men between 65 to 74 years. Approximately 300,000 men are diagnosed, which is including like 1 in 8 men. Okay, between the age of 65 and 74. This for a total of 35,000 approximated prostate cancer related mortality, which represents 2.4% in men. That was in 2022. Okay. One thing I want to point in this this slide is pretty much if you see the ages between 65 to 74. You think about the context, this is men who are close to retire, or they're already like envision their whole expectation to live a new life after being retired. So they're trying to what we call the golden years of the life, having the best quality of life possible. And all of a sudden, because this is the most frequent age of being diagnosed, you are diagnosed with prostate cancer, or your plans of like living those golden days are pretty much over. And there's a increased rates of depression in all of these patients. So that's why okay, just this is why this program is so important. So among the treatments of prostate cancer, robotic assisted laparoscopy is the most common surgical intervention performed nowadays in the United States. Approximated between 85 to 95% of the prostatectomies are performed robotically. And this actually represents a good advantage in the treatment of prostate cancer, but also in the road to the recovery after this type of procedures, especially because since the development of the newer techniques, the nerve sparing technique, the outcomes of the surgery are incredible, satisfactory, and in terms of recovery wise, including erectile dysfunction, stress urinary incontinence, are extremely improved compared to the previous type of technique that was the classic open technique, where we were not able to like see in detailed fashion what is being to be preserved nerves. Okay, so the other forms of treatment that we have is the energy treatment. Some of the patients are advised to get an external beam radiation therapy, brachytherapy, proton therapy, and cryotherapy amongst the most commons. And this is because some of the patients are afraid to get into a robotic assisted laparoscopic prostatectomy because they heard from their parents or sometimes like grandparents about friends that were undergoing to a prostatectomy because of the cancer, and they ended up having erectile dysfunction or stress urinary incontinence. So sometimes this is when being a basically a healthcare provider, it's very important, because we not only provide the health, we're also giving the educations to all our patients among the treatments and the options of treatment that they have. And this is why it's so important also to refer to the specialists, so that way they can have a good advice before getting into a other type of treatments. Okay, and exists also medical treatment, and this is what we call androgen deprivation therapy. One of the things is that prostate cancer is being hypothesized that there's androgen receptors within the prostate that actually, when you have metastatic disease, the deprivation of those androgens cause control of the prostate cancer cells. Okay, so creating patients with hypogonadism or low testosterone levels. So among the cancer survivor programs, we call all the survivors, they will experience during the roadmap to the recovery some erectile dysfunction, some stress urinary incontinence, some overactive bladder incontinence, okay, and hypogonadism. So this is what we create this type of survivorship program, would include a restore, or what we call rehab, okay, of the functions, the contingency program, where we try to reestablish where the patient was prior to the surgery, or including other interventions in order to optimize his recovery. And at the end, the surveillance and the recovery, it will be the last part of the treatment during the program. So why this happened? Pretty much during the surgery, in order to remove the prostate, as I'm showing this slide, we had to go and remove the organ, the gland, okay? But for this, we need to separate from the bladder and from the urethra. So when we're doing this, we're taking one of the two sphincters that man has. We have the urethral sphincter that is as it shows in the slide, and we have the radial sphincter that goes away with the prostate. So now we are putting back together, sewing and anastomosing the bladder within the urethra, okay? And this will cause some change on the way that the pelvis and the urethra work, having sometimes difficulty and creating the stress urinary incontinence. Also, as it shows on the slide, you notice that we had to cut through some nerves, the neurovascular bundle. Even with the preservation of it, we have some damage, micro damage that can happen during the procedure, causing diminish the nerve conduction for the patients, in which cause a sphincter dysfunction or erectile dysfunction. And here's some statistic. As you see, between 25 to 75% of men who go into a radical prostatectomy, they have some sexual dysfunction, okay? Approximated within the year, okay? Even with the nurse period, we have that 50% of the men can have this problem, okay? Also, 50% of the men can have some sexual dysfunction after radiation therapy. So quite a significant impact, just even though with robotic surgeries, okay? So in terms of the erectile dysfunction, what we do is the first part is what we call the restore, where we're trying to achieve the where the patient was before the surgery, okay? So for this, we start a phase of rehab, where we start having and giving to the patients PD5 inhibitors, okay? That is going to explain how they work in the next slides. Then we use vacuum devices, okay, in order to restore the length of the penis and also start to restoring the blood flow to the organ, okay? Then later on in the contingency part of the program, we include the intracavernosal injections and the penile prosthesis. And among the recovery and the surveillance, we need to continue monitor this, because this is the dynamic complexity of dysfunction that during years will pass, things will change, and it will require to have the patients over the program in order to try to maintain their sexual functions. So in terms of the PD5 inhibitor, this is a medication that there's brand names well known as a Viagra and Cialis, and the pharmacological name are the sildenafil, vardenafil, tadalafil, which is shown in the next slide. And the way they act is blocking the phosphodiesterase 5, which is an enzyme that what they do is break down the cyclic GMP, and that way when they break down the cyclic GMP will increase the calcium, causing contractions of the muscle. Normally what it happens is in order to have an erection, we have the guanylyl cyclase enzyme using the nitric
The host has disabled captions.
the nitric oxide, and this will cause increases of cyclic GMP. With this will decrease the calcium inside of the cell, producing relaxation in that way in the smooth muscle cells, causing the erections, okay? So what we do is diminishing the breakdown of the cyclic GMP, all right? Causing what? This pretty much, as is showing, the relaxation of the smooth muscles will bring blood into the penis, increasing an engorgement of the veins and arteries that we have in our penis, causing the erections, okay? For this, we have this variety of medications. The sildenafil, which is starting 25 milligrams, you can go up to 100. This is orally. It has to be administered 1 hour prior intercourses. However, it will we need to advise our patients that it cannot be taken with food or alcohol because interfere with the absorption not working well. Instead of tadalafil, which is the popular Cialis, it comes in within 5 milligrams up to 20 milligrams. 5 milligrams can be done daily, can be given daily. Okay, a difference in sildenafil, it will absorb with the food and alcohol, having a better response. And vardenafil, it's another type of medication similar to tadalafil, which it does not interfere with other phosphodiesterase inhibitors that we have in our body, because one of the problems with sildenafil is not selective to the 5 inhibitors. Okay, it's we can have other receptors in the retina as PD6. Okay, and the PD6 will interfere with the color, and that's what the patients sometimes complain about, having bluish color type of vision while they're taking this medication. Instead of tadalafil and vardenafil, they're very selective. And for me in my practice, this is my primary go-to in terms of these medications. Okay, so we have this patient who underwent to a radical prostatectomy. Is a young guy between their like mid-50s up to their 60s. Okay, and what we do is after the removal of the Foley catheter on week number 2, we start giving the patients right away tadalafil in order to start the restore. Okay, and we include during the therapy, we include the vacuum erectile disc bias. The vacuum erectile disc bias, as it shows, is a cylinder that goes around the penis, and what it causes is through a mechanism of negative pressure suction, okay, will bring blood into the corpora, creating a dilation and creating a erections. And afterward, using a compressing band around the base of the penis, it will maintain that blood that was bring with the suction process. Okay, so one of the important things about this therapy, it will maintain and restore the length of the penis, because it's been shown that when patients have erectile dysfunction, they can have a decrease in length between 0.5 centimeter up to 5 centimeter per year of having erectile dysfunction. So not only the patients will suffer and having not been able to perform, but also they're having the fear and the anxiety and the problem of seeing how the penis will shrink in time if we are not providing this type of programs to them. And actually, this is a good device in terms, since we're preserving the length of the penis, while we are placing penile implants will make have the patient come back to their normal length of penile stretch. Okay, this is another therapy that we use, and especially in those patients who will start failing PD5 inhibitors, but they don't want to be surgical candidates for penile implants. And this is what we call intracavernosus injections, where it's a mix of medication where it includes phentolamine, papaverine, and prostaglandins. Okay, and these 3 medications needs to be injected and delivered directly into the corporal tissue of the patients, as it shows in the pictures, between injections between 1 to 3 o'clock and between 10 to 8 o'clock, giving and delivering the medication. These are very well known medications. They're actually very strong at the point that we have to advise the patients to they can have in a priapism, which is a maintain and sustain erection for more than 4 hours. That can be painful. And one of the problems is we have entrapped blood within the corpora. This can actually be painful for the patient, as well can distort the oxygen supply, having problems and calcifications within the corpora, decreasing the elastic function of the penis and the corpora itself, so diminish the length of the penis. So it's something that has to be very well, the patient needs to be very well trained and very well educated in where they need to place the injections, as well all the some of the complications that they have about the priapism. Okay, one of the problems that this therapy has is there a high dropout rates within the patients are diagnosed. We have approximately 50% of the patients will drop the therapy in a year. So then the question is what we should do next. In this sense, we have the penile prosthesis, which is a good, well, reliable therapy, which is concealed. Okay, one of the problems is like we need to start educating our patients that having a penile prosthesis should be as normal as having a knee replacement, a hip replacement, or even a shoulder. Okay, because at the end of the day, is the education that we provide to the patients that will feel more comfortable looking for help, especially when they're having this type of problems. Okay, normally, and in United States, a patient takes 7 years to see a urologist specialist in erectile dysfunction before getting treated. So just imagine those 7 years of the patient's life that can be miserable in depression as well. The problem is, you know, like they need to satisfy their partners. Okay, so most of the patients can go into divorce and some like severe depression, and just having a consultation with one specialist can help to restore the sexual life. The depression index goes up. So that's why it's also important to have this type of classes for you guys. So among the penile prosthesis, we have the malleable, okay, which is as I show on the right side of the slide, is plastic silicone rod that is covered with nylon type of strings inside of the cylinders, okay, that they are semi-rigid, so they can be bendable. Okay, so since we had to put this in a surgical procedure, very short, less than an hour, okay, outpatient patients later on they can start using, but they have the appearance that they always erected, so that's why it's semi-rigid, so that way they can fold it and hide it inside of the pants or underwears. Okay, good thing about this device is especially for those patients with poor manual dexterity, they cannot use a pump, which I'm going to show later on how it works, the 3 pieces, the inflatable one. And it's very simple for patients who have very difficulties to understand and they don't have that knowledge in order to learn how to pump. This is a good options. Okay, this is what we call the inflatable penile implant. Okay, it's made out of silicone and Dacron. We have what we're doing in Mimic is the natural erections of the patients. Okay, so as I mentioned before, we have 2 cylinders in the penis that they fill up with blood. Those are the corpora cavernosum. Okay, what we do is during a surgical procedure that will take less than an hour with a small incision big enough to have the pump, which is this part of the device, okay, being able to get into it. We go down into the corpora, open a small corporotomy, and we just substitute our natural erectile component with this inflatable device. Okay, and as you see, they have a reservoir. The reservoir is included in the abdomen through the same incision, okay, among the perineal area or the infrapubic area. And this is filled with saline. As you know, we're made of approximately 70% of saline in our body. And what we do every time we want to have an erection, we just pump the bottom part of the device, which is this, and this will fill up with the saline from the reservoir inside of the cylinders. And this is what's going to replicate the erections. Okay, as you see here on the slide, it's very common. Okay, and it's been in clinical use for over 45 years. Okay, and more than 500,000 patients have received treatment implants at this point. They are made to last up to 10 years, and patient satisfaction is incredible, between 98%, including like 95% of the patients will recommend to a friend. Partner satisfaction between 96%. One of the problems is that it will require manual dexterity, so the patients will need to learn how to use it. Okay, what I tell to my patient, this is like similar to having a knee replacement. you go into a surgical procedure when we do and place the prosthesis. Prosthesis are foreign object that can get infected. The infection rates are between 1 to 4% national wise. Okay. And afterward, you need to go to a rehab when they're learning how to pump the device and getting used to how to inflate and deflate. And then later on, they can start using. Same as having a knee replacement, okay? During the prosthetic placement, you can damage some neighbor structures as the urethra, as the bowel, as the blood vessels, but this occur very rare. It's been described. We always have to advise the patients in counseling during before the surgery, okay? And this is how the implant works. This is a video of the replica. As you see, you have two cylinders. They are inside of the corpora of the urethra, and when you need to have an erection, you just pump with the pump, which is in the scrotal area next to the testicle. And once you got and achieve an erection, you perform. You just need to press the bottom in order to deflate, and the prosthesis is completely deflated. Okay. Okay. Another problem that we have and with the patients after radical prostatectomy is the stress urinary incontinence, and this is the reason why a few patients they don't want to go undergoing to a surgery just because they can have a stress urinary incontinence. It's extremely correlated with the prostate surgery. Up to 50% of the patients will report leakage immediately right after surgery. Okay. And about 9 to 16% of the patients may have incontinence after 1 year of treatment. What we do in these patients is at the beginning, we're starting on the program, is we start with the rehab therapy, which I'm going to show later on what is included. But one of the things that I want to discuss with you guys and I want to bring to you is like a study has shown with people who are suffering with stress urinary incontinence, especially in males, okay? They are more depressed, they're psychological distressed, they're emotional disturbed, and they're socially isolated. Because just imagine when I said about the age of the patient between 50s to early 70, okay, you're trying to spend your golden years. Now you have to deal with this problem, like you cannot perform, you cannot do exercises because you're going to be on the emotional and psychological distress of not being able to push or doing some Valsalva because you're going to have some leakage. And just imagine having leakage in front of your friend while you're playing pickleball, or you're like trying to run, or even during the orgasm, they can have climacturia. So there's a big social dysfunction for these patients and a lot of psychological distress, which will affect and impact the quality of life. And actually, this is the patients that we have the best outcomes, because just doing minimal to them, they are extremely satisfied because the quality of life changed so much and drastically. So what we do at the beginning, we try to provide short-term solutions. And these short-term solutions are behavioral modifications, where we're trying to advise the patient to reduce the fluid intake, to start to increase the uses of the bathroom, to try to plan and time the uses of the bathroom, so that way we have and maintain low volumes within the bladder. And there's others short-term solution, which is intervention, and this is the first part. So just imagine the patient just underwent to radical prostatectomy. We just remove the catheter. They have been week number 4, and they start experiencing a stress urinary incontinence. So what we do, not only focus on the restoral erections, we also send the patients to physical therapy for the pelvic floor, where they do Kegel exercises and they perform biofeedback, okay, in order to understand how the mechanism of the pelvic floor needs to be used and contract in order to maintain the urine within the bladder, okay? There's other coping mechanism, which are the pads, the diapers, clamps, or condom catheters in order to have the patients while they're trying to find a long-term solution. As what, doc? Basically, we perform two types of surgeries as a long-term solution, and these are the sling, which are mesh type material made out of different options on the market, and we have two types. We have the adjustables and the non-adjustable. As you see on our far left on the slides, these are the non-adjustable, which is as mesh that we put under surgery. Very quick type of surgery, outpatient as well. And what we do is we try to provide like a hammock mechanism to the urethra. So every time the patients sneeze, cough, and do some stress maneuver, when there's pressure in the pelvic floor, this will move the urethra downward. And what we do is provide and support the support mechanism of the mesh in order to coaptate the urethra, having a continent mechanism, okay? Not every patients are candidate for this. They need to have some residual function of the sphincter that we need to evaluate during our clinic visit, performing cystoscopy, and doing some cough tests during our investigation in order to see if the patients have residual function and they're to be good candidate for this type of procedures, okay? We also have the adjustable sling, which as you see on the right of our screen, we have this model called the Remix sling. What we do is place a mesh material within the suburethral place, as we see here, okay? And we have two arms tensioning that goes to a body tensor, and the body tensor is connected to a screwdriver. So what we do is we perform the surgery, we have to admit the patient, stay overnight, and in the morning, fill up the bladder and removing the catheter and doing micro adjustments of the sling. We find the adequate tension in order to provide a good mechanism of coaptation of the sling. So that way we can avoid having the patient on the opposite side of the treatment, which is urinary retention. So this is optimal because sometimes the patients during years and years, they will gain some weight, they can lose some weight, and they can go to different other therapies because remember, we are talking about prostate cancer patients, and sometimes having surgery is not the only way of we are going to do and provide the treatment for the prostate cancer, because this is a disease that can evolve. Okay, it's a condition that can evolve, and sometimes patient needs more treatment. So this is optimal because we can adjust over period of times. How we adjust is a small little incision in the abdomen. We reach where the body tensor it is, and using the external manipulator, we just tied it up a little bit. Okay. So if patients are not a candidate for sling, we have the gold standard of the treatment, which is the artificial urethral sphincters, okay? And what is this? It's basically a cuff that we place surgical around the urethra and having a reservoir inside of the abdomen, which is what we call a pressure regulating balloon, okay? This will provide coaptation of the urethra. As the best example is, just imagine the cuff where we use in order to take the blood pressure, okay, in order to measure the blood pressure, but this is a small version around the urethra. And what we do is like having always coaptated at the time that is sociable, acceptable, and we have some urge to urinate, we just need to press the control pump in the scrotum area as well. So that will open the cuff, having the patients the opportunity to urinate by themselves, and then it will automatically recycle and close back in approximately 90 seconds. Satisfaction rate is extremely high, 98%, and is very well recommended to the patients. Up to 97% will recommend to another patient. It's simple to use because, as I mentioned, you just need to press the pump every time you want, and you have the urge to urinate, and it will automatically recycle back and close. So patients actually learn how to use these devices really quick, okay? Another important thing is conceal. So now the patients can go to the stadium and go next to a urinal with their friends and go in there and urinate, just pressing the scrotal area, open the cuff, urinating. Nobody will need to know that he, at some point in his life, he suffered from stress urinary incontinence. And as I mentioned before, this is the gold standard of the treatment option. How they work, this is pretty much, sorry about that, this is how pretty much they do. Unfortunately, I don't know why the video is not working, but pressing this area here will open the sphincter and having the patient being able to urinate and void, okay? And then later on, 90 seconds later, it will reinflate by itself, and it will close. So very simple to use in general. Another problem that we have and these patients have and they have to overcome is what we call overactive bladder. What is overactive bladder? Is the sense of urge and frequency, because the bladder has uninhibited contractions, non-rhythmic, that cause and send a signal to the brain to have the patient to urinate. Sometimes the patients, these uncoordinated contractions will be joined with some urge incontinence. So the patients will have urge incontinence just because the bladder will decide to contract. And why does this happen? It's fairly and most common in patients with radiation therapy. And this is because the radiation therapy is like the best example that I give it to the patient is like a burn. Okay, it's a burn into the bladder. And as we know, the radiation therapy will stay in your body. And in the same happened to Chernobyl, we're still measuring reactive ciphers in the soil. You're gonna still have some radiation in your body all time and causing some irritation to the bladder mucosa and to the detrusor muscle within the bladder, causing overactivity. Mostly is a medical condition that we're trying to treat with anticholinergic medications or beta-3 antagonists, okay? What they do is calm down the uninhibited contractions within the bladder. Sometimes we may need to perform invasive therapy, and this is in the options of pelvic floor therapy, where they have to go to rehab therapy and sessions in order to calm down the pelvic floor, okay? There exists neuromodulators and chemodenervators that we use. What are you talking about? So neuromodulators, we have the posterior tibial nerve stimulation, which is a root of the S3 and the sacral nerve that we found in our posterior tibial behind the malleolus, okay? 2 finger breadths behind and 2 finger breadths above the malleolus, okay? And what we do is using an acupuncture needle, we find the target area, placing the needle and connect it to external stimulator. And this has to be done for an hour for 12 weeks. And what they do is send a signal from the nerves, the same nerve that innervates the bladder, to the brain. So that pathway is reactive, and the brain will reestablish how to control and relax the pelvic floor. However, one of the problems with this therapy, the patients will need to have a lot of free time first. Just imagine 1 hour every day of your life for 12 weeks, okay? And and then later on you have to deal at least once a month, one time. So it will require a lot from the patient. So that's why it's something I don't see. It's been done here in the United States, but however, in places like Europe, they have physical therapists that goes to the houses, and they are being trained in order to do this therapy, and it's very well established programs over there. Hopefully in the future, insurance will let us perform this, and so it will be a good therapy for some of the patients, okay? Just imagine you can go to an office and place this, they are doing their normal activities, okay? Now, if this doesn't work, we also have another type of neuromodulators, and this is the inflatable form. It's a pacemaker of the bladder. So we place this under surgical. What we do is we find the S3 root and we place a lead in the same way we place a lead in the heart, we place in these nerves, and this is connected to a small pacemaker, and this pacemaker will be able to be controlled with a remote. So it can be programmed with different type of stimulations and in pendency, okay, with current stimulation. And what they do is basically send constant signals to the nerves in order to calm down the bladder and being able to treat the overactivity of the trusor muscle, okay? What I've been showing on the left hand is the axonic, sorry, non-disclosed for this, but it's one of the few on the market that is rechargeable, okay? So once you implant the device, the patients can recharge this at least 1 time every 6 months. So it's very convenient. And as you see, the remote, okay, in order to control the different plans of treatment is very simple. It's just like having an alarm of your car, okay? Another thing that we can do is chemodenervation, and what it doesn't mean is injection of Botox, okay? As you know, Botox relaxes muscles and inhibits contractions, okay? And this is a therapy that we can do in the office, which has a really good response. However, the only problem with this, in the same way Botox wear off in time, okay? The same Botox will wear off in time in the bladder, so it will require multiple sessions in order to calm down. However, it works extremely well, and since it's an office procedure, patients likes and is well tolerated with the patients. So what we do is place an cystoscope, which is a telescope camera that will goes inside of your bladder and will examine the bladder walls and be able to do a template of 10 injections with 1 cc each injections in the pattern and the form that I'm showing in the right part of the pictures. And with this, I think we are concluded our brief talk about what is surviving prostate cancers means.
Dr. Cedeno, what a comprehensive presentation of all the options men currently have after this very radical type procedure. One of the things that always is in the back of the patient's mind is precisely some of the things that you spoke about, which is obviously after the denervation or after the nerve damage, what about now the sexual life of that particular man? So we have spoken in the past and we have talked about the sparing, the nerve sparing being one of the methods that now urologists or uro-oncologists are using in order for the man to retain at least some activity. In your experience, in those particular types of surgeries, what is the failure rate in the nerve sparing type procedure? Is it always successful, or do you also see opportunities there where the technique perhaps wasn't optimal or simply did not work for that person?
So one thing that I have experienced is like I had the opportunity to practice in like 2 different countries. I had the opportunity to practice in Venezuela, where I formed as a doctor, and over there we didn't have robotic treatment at the time. So I noticed there were like more stress urinary incontinence. So since we introduced the robotic platform and the nerve sparing technique, the stress urinary incontinence is probably something that is gone, okay? It still exists, okay? More in radiation therapy, but the erectile dysfunction is still like 50%. The problem is with the erectile dysfunction that doesn't happen with the stress urinary incontinence is a dynamic problem, okay? Because just putting in context, the age of the patient plus the comorbidities has like diabetes, hypertension, medications will play a role in the disease. So and also some of the patients that we are seeing is they already have some degree of erectile dysfunction prior to the surgery and will be exacerbated, okay? So still very fair, very common, like 50% is actually the quote unquote between, let's give it some broad options to my oncology guys, is 25 to 75, let's say, okay? But still, okay, one of the important things is to discuss with the patient, being honest at the beginning of the procedure and show that they have opportunities to restore their sexual life, because some of them, their thing is, oh, I fail as men, and at the end of the day, it's not that they fail, it's just a disease like every other things in the world.
Right. And you mentioned something extremely important that is sometimes passed in the initial investigation or initial consultation with the patient, where the physician fails to actually highlight and recognize the fact that the person, the man, is already in some kind of dysfunction due to diabetes and due to the other comorbid conditions that you actually mentioned. So it is important to highlight that specifically, simply because we don't want a patient to return to your consultation and say, no, but I'm not functioning like I used to. So that is one thing. And the other is obviously the options that you have given us in regards to resolving some of these particular issues that men will encounter. Obviously, the incontinence is one that plays an important role in the lives of a man, especially after these very radical surgery. And the other one is, of course, those that want to proceed and undergo procedures to correct erectile dysfunction. The good news, as you mentioned, there is chemicals and medications, to say it better, that could also assist in returning to the prior sexual function. In your experience, is that alone sufficient for the man to recoup some of the prior functions, such as the sexual activities?
Yes, actually, it's the first line of treatment to begin with, because it's very effective, first of all, because one of the things that happened with the erectile dysfunction is the psychological component of the erections. Okay, so sometimes the patients just need a little bit of boost, okay, and their psyche will, and their motivation and everything will be restored, and at the end they'll start like either stop using the medication and restore their sexual functions, or sometimes just with the medication they don't need to go under surgery. So it's definitely a form of treatment. Also, not everybody's a surgical candidate for like a penile implant, okay? Some patients, they cannot, and there's where injections played a good role of it, and actually the vacuum therapy. Okay, so that's why it's so important to get the consultation with the specialist, because we have other like multiple options to the patients, and it will depend quality of life, lifestyle of the patients, comorbidity, everything that have to. I believe we have a questions within the Q&A.
And it's from Ms. Carrion, and she says, good afternoon. Do you use any scores to evaluate initial status of the patient?
Yes, we do. We have a couple of scores. We have the Sheen score, which is actually the one that we use for male and female with lower urinary tract symptoms. Okay, and what it gives us a good information regarding like overactivity, urgency, frequency. We also use the EIIF. Okay, which is let's say it's an erectile function score that can tell us which patients are already having some issues and some trouble. Okay, we have a continent for females. We have one specific as well. Well, this is not part of the lecture, but yes, we do, and we use it a lot, especially because it's the thing with the questionnaire is like we can assess how it changed, okay, during the therapy. And since we repeat it multiple times, we also can see which patients can tell us some improvement or not. But yes, we use it. And also, I didn't mention, but there's a way of there's ways that we use in order to study the degree of erectile dysfunction. And one of them is using the penile Doppler ultrasound. It's a test that we do in our office, where what we do is while we're teaching the patients how to do the intracavernosal injections and we are looking for the response of the medications, we perform the duplex ultrasound and we see where the trouble it is, because sometimes the trouble can be in the arterial phase of directions, sometimes can be in the venous phase of directions, or sometimes just a psychological component of it. So we can add a value and show to the patient where the problem it is. And it's actually, I use it a lot for decision driven into the patients where, hey, listen, you already have a trouble. It seems that doing this is not going to work. Let's go to the next phase. And it's actually a simple way to have the patients going to the procedure, as well to get back into the form that they were before the surgery.
Mm-hmm. What is the age bracket of those patients that you currently see that are or end in a radical prostatectomy?
So, based on the American Urological Association guidelines for prostate cancer, every man between the age of 45, okay, some of them, I'm going to be very vague on this, up to 70, okay, years old, are the ones who need to go to a screening. Okay, what's the screening entails for? PSA, the blood test, and digital rectal examination. Okay, and the reason why I said between 45 and 50, let's say those group age, is because you need to have in consideration the race, you need to have the considerations, the past family medical history, and sometimes the history, the other history that the patient have. Like, for example, they well know that patients who have like these rare forms of more familiar disease of cancers, they can be related to prostate cancer as well. So that's why we cannot put everybody into a box. And between 45 to 50, if they're like risk, between 50 to 70, everybody. Okay.
Mm-hmm.
And some patients above, sorry, some patients above 70, it will depend on the life expectancy of the patient. I see patients in my office with 17 years old that are like, wow, tell me what you have done in life, because I just want to be like you, you know?
I know it. I see them at the gym all the time.
Exactly.
So Antonio has a question, and he says, can Kegel exercises resolve reactive bladder conditions, overactive bladder conditions?
Yes, it can, because we can use it as part of the physical therapy. As I mentioned in one of the slides, there's one thing that called biofeedback. And the biofeedback, what we do is, while we're placing a visual, a graphic, like table, okay? Sometimes it's just, let me move forward on the idea so you guys understand what I'm trying to explain. It's like we put sensors on the patients on the pelvic floor, okay? And while we put in sensors on the pelvic floor, we have an active response every time they contract the pelvic floor into the screen in a form of like, let's say like a bar. So every time they contract the pelvic floor, okay, these bars will go up, and they able to create the pathway between the brain and the pelvic floor. And it's not about the Kegel that will help to contract. It's about how the dynamic of between the brain and the connection of the circuit within the pelvic floor will help to restore the normality of the uninhibited contractions of the overactive bladder, but also will help the patient with stress urinary incontinence that they have like pelvic floor dysfunctions.
You know what, Dr. Cedeno, this is such an incredibly important topic, especially for men nowadays. The fact of the matter is that we have changed in leaps and bounds in regards to early identifying conditions such as prostate cancer. The fact of the matter also is that men really need to be cognizant of the risk and go to the well-man check, similar to what a woman does. A man has to actually be committed to checking periodically for his PSAs and obviously the rectal exam when applicable, in order for the urologist to have an early identification. Not all cases require radical prostatectomy, as we all know. Some might be candidates for radio-oncology, and there are great techniques that also spare some of the issues in the rectum, such as a hydrogel and other incredible new devices that we use. So, and we're encouraging the students that are listening today and some of the doctors to please understand that medical semiology is not only to understand how to conduct a well or a good exam. It's more of educating at the end of what your findings are. Dr. Cedeno, it is such a pleasure having you with us. I am so thrilled that you have joined our group in Baptist Health. By the way, for those of you that do not know, Dr. Cedeno is new to Baptist, and we are thrilled to have you with us. And with that, I would like to just, again, thank you for allowing us this informative presentation, and to all of you for participating and attending today's lecture. If you have additional questions about
Baptist Health has started screen sharing.
If you have additional questions about today's presentation, please feel free to email it at BHIWebinars@baptisthealth.net. That's BHIWebinars@baptisthealth.net. We'll make sure to get them to Dr. Cedeno for him to complete and send back to you. We look forward to seeing you all at our next medical lecture series, which is scheduled for November 8th, 2023. In the meanwhile, have a phenomenal rest of the summer. Thank you so much, and have a great afternoon. Thank you, Dr. Cedeno.
Thank you, everybody, for having me. My pleasure.